preparing for taking your exam this year or the next year in the new system, you have to know how to approach the station in a good way, in a structured way, so you are not going to miss anything. So starting our meeting by definition of the four main issues in communication, which is the autonomy. Autonomy is the patient right to accept or reject treatment or investigation based on fully informed consent. Beneficence, which means do no good for the patient. Non-maleficence, do no harm for the patient. Justice, which means all the patients have the right to receive the same quality of care regardless any issue, whether financial, ethnic group, or social status, or whatever. There are some issues related to these topics, but I'm going to tackle on its place. Starting with communication skills, there are four main pillars for communication. The first step is fixed in all patients. It includes identifying yourself, greeting, introduce yourself, take permission for the meeting, confirm the identity of the patient by asking him, let me assure that you are Mr. or Mrs. Fulan. If you are talking to a relative and the patient is conscious or competent, you have to ask the patient, the relative, I assume you took permission from Mr. or Mrs. And name the patient to talk about his condition. Even if it is written in the paper outdoors that he took already permission, you should ask about this. If the patient is unconscious or not competent, you ask the relative if he is the next of kin of the patient. After this, you start by setting the aim of the meeting, why you are here today, to discuss the result of the investigation, to discuss his problem, whatever, and also finish the first part, which is the introduction part, by asking the patient, how do you feel today? This is the first item in all communication stations. It is fixed. The second item is checking the patient knowledge, which is called ICE, idea, concern, and expectation. You ask the patient or the relative how much he or she knows about his or her condition, and what does he expect that he might have, or the result of investigation might be. And if he has or if she has any concern. In communication, the issue is slightly different from station 5 and history taking. You ask about concern nearly 3 times because sometimes the communication scenario all are running about the concerns. The second step is also fixed to all stations. Hello? The second step is also fixed for all stations. The third step differ according to the situation. It may be dealing, breaking bad news, dealing with angry patient, counseling, whether about disease, investigation or treatment, or counseling about end-of-life care. There are different types of counseling about genetic tests, counseling about or genetic disease, and counseling about HIV. This is a big item which has certain items that you have to fulfill when you are dealing with such topic. Dealing with angry patient is another topic, breaking bad news, and special situation like abortion or situation of uncertainty, dealing with uncertainty. These are the main topics that you are going to face in your exam. For each topic, you have to prepare yourself what are the items that you are going to talk about. Then the last step is the closure. You summarize your meeting, the important items, and the take-home message that you stress on the patient to know. Also, you ask the patient about the concern and properly manage his concern. And be sure that you fulfill the patient concern when you answer it. And it is smart enough to ask your patient Do you think I properly addressed your concern? Do you have any other concerns? Check understanding of the patient, how much you got from our conversation, or what is the take-home message you got from our conversation. And lastly, put a plan of management, including the help. Help may be a sort of support group, maybe a society, maybe someone to transfer him home according to the situation. After this, you move. Again, I'm going to stress that the first, second, and fourth step are fixed in all scenarios. The second step is only different. I'm going to start with breaking bad news. In breaking bad news, usually these are the steps that I talk about. There is certain approach for breaking bad news. It includes, first of all, that you have to give a warning shot. I'm sorry to tell you that, but the result of your test reveals some serious result, or it's not as good as we hoped, shows something serious. Hi, are you following me?
Yes,
So you have, okay. So you have to use warning shot first. As I told you, I'm sorry, I have some bad news for you. The result of your test is not as good as we hope, or the result of your test reveals something serious. It is important to ask your patient how much you want to know about your condition, because people differ in their reaction to stress or to bad events, bad news. And people differ in the extent to which they want to know about their conditions. So this shows the examiner that you appreciate different kinds of personality. Those who want to know everything about their condition, or just want to know how they are going to proceed, what is the next step only. They want to bother themselves by a lot of information. After the warning shot, do what is called golden silence. Just keep silent till the patient starts to ask you. Then you start to explain the situation in a simple, non-medical terms, using simple words which is appropriate, organized, and does not include any medical terminology. It is important to know it is not the amount of information you give to your patient which matter, but the type of the information and how you deliver your information and how you check his or her understanding for this information. So it tests this station tests your communication skills, your ability to communicate with your patient, deliver the information in non-easy, digestible way, stress on the important point and the important take-home messages. It is important to give the information in small chunks, small pieces of information, and keep silence. And if you lost the eye contact with your patient, it is very important to stop and ask him, are you following me? Do you want me to repeat anything again? Is everything is clear for you till now? Appreciate the non-verbal clues. If the patient starts to turn his head or look sad, you should tell him, I'm sorry for that. I appreciate it could be hard for you to hear this news. Everyone in your situation would be hit. But be sure that all the team here is beside you in order to help you and give you the best care. Important in breaking bad news to ask about pre-morbid condition. with whom the patient lives, and about the home support. Sometimes the habit may be of value in certain situations if it is relevant. This is for breaking bad news. The item of the topic of your talk differ according to the scenario. If you are breaking bad news, it is important to stress on the warning shot, the golden silence, the way of the breaking bad news. Excuse me for a few seconds. Thing in breaking bad news is to keep the structure of the scenario, give the golden silence after the warning shot, and give the information in a simple, small pieces of information. Check the patient understanding and put proper plan of management. Then close the interview. It is very important to encourage positive outlook, but be honest. Don't give false hope. So if you are talking about, for example, a terminal disease or non-treatable disease, you should look positively. Tell the patient, don't worry, we are all here to help you. We are going to keep you free of pain and suffering. It is very important, but don't give false hope. If you don't know any part of the information, it is important to acknowledge that you don't have this piece of information right now. You are going to recheck with your senior, with your colleagues or whatever, and then tell the patient his answer. Don't volunteer an answer which is you are not sure about. If you are not certain about the answer of the question of the patient, just prefer or tell him that you are going to recheck and tell him the answer by the end of the meeting. It is very important to keep empathy and react to the patient verbal and non-verbal clues. Non-verbal clues include the body gesture, the eye contact, and the facial expression. That may give certain clue that the patient feeling sad or angry or whatever. So you have to react appropriately. Don't forget psychological and home impact and asking about who is supporting him, whether socially, financially, in the occupation. It is very important in a communication station to listen. Very important to listen to your patient. Allow the patient to express his emotions and react appropriately. If the patient or surrogate does not react, does not express his emotion, you should express his emotion. I appreciate it could be hard for you to hear that. Would you tell me how do you feel right now? What is running out in your mind? And very important in breaking bad news to check the patient understanding at regular interval. Besides checking the acknowledgement at the end of your conversation. This is station made to test your ability to break bad news in a structured, clear, and empathetic way. So keep conversation simple, clear, and focused. Don't go deep into complex medical information, but you have to talk generally and briefly about the important items in each part that you are going to talk about. Patient reaction to bad news differ. Maybe anger, denial, sadness, griefness, or acceptance. I'm going to stop right now for a few seconds and listen to your comment before going more deep. Is there any question? Any question? Mm-hmm.
Thank you.
Okay, I'm going to continue.
Go ahead, Doctor. Yes, please.
The first item in breaking bad news, and the most serious, is breaking bad news about cancers. You should know what are the types of cancers that you are going to face in the exam and why. And what are the important topics that you have to stress on in dealing with each of them? For example, lung cancer. Lung cancer is the first leading cause of death worldwide, so it is commonly appearing in cases. So you have to know some information about lung cancer. So you have to know that which type of lung cancer related to hypercalcemia, which type related to hyponatremia. Small cell lung cancer generally never treated surgically, so you cannot give surgical option if the patient has small cell lung cancer or the investigation reveal hyponatremia. This is a clinical issue that you should be aware of. He will not clarify it in the scenario, and usually the comment will be and manage his talk to the patient about the result of his test or scans and management plan. He will not specify the management plan because these knowledge are important or basic medical knowledge that you have to know. Small cell lung cancer not treated surgically. They are treated palliative, whether chemo or radiotherapy or a combination of both. Non-small cell lung cancer can be treated surgically provided they don't have metastasis, they don't have spread to the other lung, they don't have lymph node metastasis. There is no evidence of superior vena cava obstruction, phrenic nerve paralysis or diaphragmatic paralysis, or malignant effusion, and the transfer factor. So if you have any of these items, you are dealing again with advanced stage cancer, and you are talking, you should raise the issue of end-of-life care, not simply lung cancer and treatment. I'm going to refer you to oncologists to discuss the surgical issue. There is no role for surgery in this situation because it signifies non-operable cancer. Usually, if there is metastasis, this means you have to raise the issue of end-of-life care and palliative treatment in cancer. Also in small cell lung cancer. Small cell lung cancer, aggressive type of cancer, worst prognosis. As mentioned, the contraindication for surgery. This is very important. So in lung cancer, he will give you a scenario. Like the scenario you can see. Mr. Edward, 40 years old, smoked 10 cigarettes a day for the last 40 years. He admitted a week ago with cough and shortness of breath. Investigation were normal, apart from slightly low serum sodium. High resolution spiral CT of the chest demonstrated left side hilar lymphadenopathy. So there is hyponatremia and hilar lymphadenopathy and no evidence of mass. This is the clinical data in the scenario that you have to interpret. If I'm going to talk about cancer, so it most probably non-small cell lung cancer, so I'm going to confirm this by certain investigation, like bronchoscopy and biopsy, and then refer him for palliative care if it is proved to be. Okay, so from the scenario, you have to have a clinical issue that you base your discussion on. The next cancer that you may face in your exam is mesothelioma. It is one of the common cancers appearing in the exam. Why? Mesothelioma related in most of the cases to asbestos exposure. So it is related to the job, and the patient have the right to compensate for compensation. So it is very important to raise this issue even if the patient didn't ask about it. If the biopsy revealed mesothelioma or the investigation revealed mesothelioma, you have to raise the issue of compensation. So as you are going to see while we are discussing different types of cancer, there is a clinical issue or a legal issue or ethical issue in each of them that you have to be aware of and raise to your patient. This is important in the old system of the communication, but more important in the new system, because there will be no discussion with the examiner. So you have to cover all these aspects in particular. The third and fourth types of cancer, esophageal cancer and pancreatic cancer. These are aggressive cancer, and it is known that it is not operable cancer. So if you have patient with esophageal cancer or pancreatic carcinoma, you are going to talk about end-of-life care. This is very important to know. You are going to talk about palliative care. There is no treatment, no rule of surgery in this condition. So it will not be mentioned in the scenario. The scenario will mention that, it came in the last slide, esophageal cancer, patient coming with repeated attack of hematomas and diagnosed finally with esophageal cancer. The patient relative is angry because of delayed diagnosis. It is one issue, but the other important issue that esophageal cancer, once diagnosed, is inoperable. So it is very important to be clear in this issue. Lymphoma is another type of cancer commonly appearing in the exam, which is on the other side of the spectrum. It is a curable cancer, curable type of cancer in most of the cases again. If you have lymphoma, you have to, a scenario usually comes as either counseling about Hickman line or counseling about lymphoma itself, or the patient already diagnosed with lymphoma and going to start chemotherapy, and you have to talk to him about this. There are certain items that you should raise in this scenario, and this is very common scenario. First of all, the importance of being curable cancer. It is very important to stress on the long-term follow-up after treatment. Number two, the job of the patient. This patient is going to take immunosuppression. Usually in the scenario, there is hidden issue or hidden agenda in the job in such scenario. Like it appeared in the exam before, he is working as a social worker in school, infection disease control clinic in a school or in a clinic. It is very important to ask about the nature of the job because he is immunocompromised patient. He is liable to get the infection easily. Thirdly, being affecting the fertile age group, it is very important to tell the patient that his problem is going to affect his fertility. So it is better to keep his ovum or sperm in a sperm bank or ova bank because the treatment affects his fertility. Again, you have to in such situation stress on the some of the bad effect or side effect of the chemotherapy. The next type of cancer is prostatic cancer. Again, it is good prognosis cancer, one of the cancers with good prognosis, but you have to stress on the importance of long-term follow-up as any curable cancer. Also, it is important to stress on the job, and in prostatic cancer, patient may be concerned about the disfigurement that's going to occur after surgery. So you have to check or tell him that there is prosthesis, artificial prosthesis, that going to correct this disfigurement. The next type of cancer, prostatic cancer. Prostatic cancer again is one of good prognosis cancer, good outcome cancer. Sometimes if it is not metastasizing, it may be cured by hormonal treatment. Astrocytoma of the frontal lobe is another type of cancer that comes in the exam frequently. A wife of a husband have astrocytoma of the frontal lobe. The issue is not in the astrocytoma itself, but in being in the frontal lobe. So it affects the patient behavior. So it is important to ask the patient about the hospice care. If he cannot deal at home or cannot have a problem in cooking at home, there will be what is called hospice care. So very important to check this issue. Another cancer that commonly appear in the exam as well, colorectal carcinoma, Jux A. This is a very important type of cancer. It is curable cancer. It is intramucosal cancer, completely cured with surgical treatment. But here you have to stress on the importance of doing colectomy, whether partial or complete colectomy, and colostomy. And you should explain the colostomy in details. So this is again another clinical issue that you have to raise despite it is not being mentioned in the scenario. Another common scenario in cancer is malignant effusion in young female. Malignant effusion in young female, malignant effusion means it is a stage 4 cancer. You don't know the primary, where is the primary is, and you don't have to search for it. Here, it is a type of dealing with uncertainty. You are talking to the patient, you don't know where the cancer starts, and you are talking about palliative care, and the patient is insisting to know where it started, and you try to convince her that it will not differ in the management. So just now we are in a situation that your cancer is advanced. I'm sorry to tell you that, and what we are going to do right now is to start what is called palliative care with her for you, and explain what is the meaning of palliative care. Another common scenario is thyroid carcinoma with cerebral metastasis. Here it is very nice scenario because it is testing two issues. It is cerebral metastasis, so are going to talk about end of life care. It is stage 4 cancer. But why he mentioned thyroid? Don't forget that one type of thyroid cancer has familial autosomal dominant nature, which is part of MEN2, which is medullary carcinoma of thyroid. So you have to ask about family history of gland cancer or surgery or that. And you should stress on the importance of screening of the first degree contact for this cancer. This is very important, and you should be aware about this clinical issue when you are dealing with such situations. Malignant melanoma in young patients. Malignant melanoma usually affect from 15 to 30 years of age, so it affects young generation. And if it is localized, it is completely curable, one of the good prognosis cancer by excision, radio, or chemotherapy. It is important to stress on the patient to avoid sun exposure because it is commonly occurring in fair skin when they are exposed to sun massively, and to do what is called regular self-screen, to check if any lesion appear. So she has to notify her GP or physician, and also the importance of long-term follow-up. This is one scenario. But the other more difficult scenario that the patient came months before with suspicious drug in her skin, and her GP told her that it is just nevus and no need for any further intervention. And she came later on with metastasis in her liver and lung. Metastasizing malignant melanoma is end-stage cancer, and treatment again is palliative care. And here, if the patient have any of the red flags, like bleeding, rapidly increasing in size, being painful, it is very important to address there is a negligence by apologizing, addressing the issue by medical record to the patient advisory liaison service if she wants to raise a complaint, and you address it to your consultant by writing a report about this, and notify high-risk management team. Testicular cancer and prostatic cancer, as I mentioned, is one of our two good prognosis cancer. These are the common cancers appearing in the PACES exam. And most breaking bad news about either cancer, end of life care, and this is separate issues that we are going to discuss separately, terminal disease or incurable disease. I'm going to stop again here for a while and ask you if any of you have any question or comment.
Hello.
Doctor, I want to respond to the frontal astrocytoma. Why hospice care? Why is candidate for hospice care?
Hospice care because the patient frontal lobe tumor affect the personality, because abnormal behavior, loss of inhibition, aggressive attitude. The patient may lose control over his behavior. He may urinate in the street. He may behave in a very strange way. So it may be difficult to deal with him at home level. In such situation, hospice care, which is a place in which the patient can have as medical help as well as social help, not only social help. Clear?
Clear, thank you.
Any questions?
Hello, Dr. Astrocytoma.
Hello?
Astrocytoma is good cancer or bad cancer actually?
There are 3 grades of astrocytoma: low grade, intermediate grade, and high grade. There are different issues. I can share a screen with you for about this issue. It depends on patient age, above 60 or below 60. If the presentation with fits in the first instance, it is good prognosis. If the patient can take care after himself, this is a good prognosis. Does not affect the behavior. I mean, if the rate of the growth, which is the doubling size, tumor doubling size, determine the nature of the or aggression of the tumor, there are certain criteria that determine the aggressiveness of this tumor. So if it is not mentioned clearly in the scenario, it is important to just touch it as a whole. You mentioned that there are different grades of this cancer behaving in different way, but you should know also that all brain tumor treated surgically plus or minus radiotherapy. There is no other option, especially if there is less effect. As I told you, there are some good prognostic factor and some bad prognostic factor. The good prognostic factor include.
Is it treatable?
Yes. Tumor doubling size. The tumor doubling size. For example, you have a CT for the brain right now. The tumor size, for example, 2 centimeters. After 6 months, it is still 2 centimeters. This is a low-grade cancer. But if it is becoming, for example, 5 or 6 centimeters after 6 months, this means rapid decline size.
We cannot go for any surgery or like that?
Sorry?
We cannot go for any surgery? Surgery
depends on the aggressiveness of the tumor and if there is intracranial hypertension manifestation. If the tumor low grade or intermediate grade, the treatment for any brain tumor is surgical. But if it is low grade, high grade, you are proceeding to advanced to end of life care.
Madam, all cases of advanced life care, we should tell about this advanced directive, all these things?
Yes, I'm going to tackle end of life care as a separate session, inshallah.
Okay, thank you.
Because it is important, we need more stress. Advanced life care and to ventilate or not, to resuscitate or not, there are 3 scenarios which is dealing with terminal patient. I'm going to tackle in a separate session, inshallah.
In the case of in a non-treatable cancer, if you are telling about this hospice, you told about that hospice admission for
the hospice care. Yes, if there is problem in coping at home, you can get the hospice care. Hospice care can be done at home, or the patient can be transferred to the place where he is going to take this care.
that case we should talk about palliative care also in the hospice.
No. The hospice care in astrocytoma of the frontal lobe is related to the behavioral changes, not to the advanced stage.
Okay.
The patient is difficult to cope with relative behaving in a bad way. They cannot deal with him. So in such situation, you release the effort from the family by either someone who take this responsibility at home, or he is transferred to an institute going to give him the proper medical as well as the psychological and social care as well.
Okay, doctor.
Okay. Any other questions?
I would like to add a small piece of information regarding this hospice care. Which is almost always we're offering this for a patient that are expected to live 6 months or less. And in this case also,
Yes.
if the patient is difficult to be dealt with it at home. And
Yes, exactly.
yeah, they will provide medical treatment, psychological support, and even they can support the family. Okay.
Yes, this is totally right.
Yeah.
You offer
Yes.
the hospice care for either end-stage patient
Yes.
or patient who has
Diffi-
difficulty to
Yeah.
cope with family at home. So
Yeah, exactly.
he cannot
Yeah.
live in a good way.
Yes,
So
right,
you transfer
right.
him to people who are qualified to deal with him.
Yes, right,
Sometimes
right.
the hospice care, you train some of the family members how to deal
Yeah.
with this patient. If they have this emotional drive that make him able to deal with the patient even in a critical situation, you train them and you give the family psychological
Yes,
support
right.
to support their patient. Because the concept of hospice care that the patient is not only the one to suffer, the carer of the patient
family.
are suffering more. Yes.
Yes. Yes, of course, it can take place at home or in a hospice center or by specialized nurse or even the hospital.
Exactly. Yes.
Yeah.
Yes. Or even the family member. Yes.
Yes, right. Yes. Thank you.
Any other question? Clear?
I'm patient with needs hospice. I have to mention this during my talking with the patient.
Yes, it is. You are going to decide this by talking to the patient. So usually, for example, the scenario of astrocytoma, you are dealing with the husband, the wife, the scenario, or the relative, whatever. And because this patient, you are not going to talk to him directly because he lost insight or lost competence. So you are going to mention to him, is it difficult to deal with him at home? Can he cope at home properly? If not, we can offer what is called hospice care. It can be done at home, or he can be transferred to the hospice center or institute. So they can provide the proper care for him and keeping him in a good shape and not suffering and so on. So it is in the conversation, not for discussion with the examiner. Any other question? Okay. This is for breaking bad news. I want just to share the screen again with you. Sorry. So I'm going back to continue our session. Doctor, who asked about frontal lobe tumor. This is the prognostic factor, good prognostic factor in frontal lobe tumor. If the age is less than 60, if present with epilepsy or fit in early diagnosis, this means the tumor is superficial or affecting the cortex. If it is low-grade tumor by biopsy and the CT finding, if it is low proliferative activity, which is the tumor doubling size. If you did total or near total resection for the tumor, and the patient able to take care after himself. And as I mentioned, the main treatment for primary brain tumor is surgical, then radio plus or minus chemotherapy. Hospice care should be offered in such situation in frontal lobe tumor because of behavioral change and loss of inhibition and personality changes. As long as the patient has fits, it is obvious that you have to stress on the issue of driving. Pancreatic cancer I mentioned about. Now about HIV. HIV is a heavy topic. It can come in different situations. I don't know if the time of the session will extend to cover it or not. But anyhow, you may have HIV as pre-test counseling or post-test counseling. Pre-test counseling means the patient didn't do the test, and you are going to discuss with him the importance of doing the test and why you want to do this test, what is the nature of this test, what is the pros and cons of doing this test. Post-test counseling, after the patient knows that he had, the patient did the test and come back with the result, you are going to discuss with him the sequel of the test. You have three situations, whether in pre-test counseling or post-test counseling, and you may face any of these situations in your scenario. First of all, patient with a risk behavior, patient who did unprotected casual relation or doing tattooing, sharing needles, one of the HIV-related behavior, and the patient is coming for you to do the test because he is worried. The patient doesn't have the disease. Here you have to mention that having HIV that does not mean that you have AIDS. The other situation, patient coming with disease-defining illness, autinophagia, and he found to have gel candidiasis, TB, lymphoma with suspicion of HIV, Kaposi sarcoma, patient with pneumocystitis carnii. Any of these disease-defining illness should raise the suspicion to do HIV test. The third situation in which you need to do HIV test is needle stick injury. One of the medical carer, whether doctor, nurse, or other medical staff, get injured during piercing a patient. These have certain items that you have to fulfill. The three situations, whether the patient have a risk behavior or coming with disease-defining illness or needle stick injury, can come as pre-test counseling or post-test counseling. There are certain items that you have to cover in such situation. If you are dealing with pre-test counseling, you have first to mention why you need the test. Explain why. So the result of your scan, or the result of your camera test, or the result of your sleep, whatever, reveals that has a disease which does not commonly affect healthy adults. It affects person with problem in their defense system. Do you have any idea about any disease that can cause problem in your defense system? Have you ever heard about acquired immune deficiency state? Have you ever checked your HIV status? Then explain what is HIV. You have to write these items and talk about each of them in 2 words for each. What is HIV? HIV is a sort of super bugs that affect your defense system, attack your defense system, making it weak, unable to combat infections or bugs. So even weak infections, weak bugs can cause serious harm to yourself. If the patient coming with risk behavior, you should mention that having this test positive does not mean you have AIDS. Or HIV positive test does not mean that you have AIDS. So you then explore a third step how can be HIV transmitted? HIV is transmitted by either sharing needles, tattooing, unprotected casual relations, or blood transfusion. Do you think you have any of these risks? When you are in communication skill, you are not going to attack your patient. You are not allowed to ask your patient, have you ever did unprotected casual relationship? Have you had tattoo, whatever, or shared needles? You are not going to take a history taking, but you do it in another way, like interview. You tell him these bugs can be transmitted by different way, including sharing needles, tattooing, unprotected casual relations. Do you think you have any of these risks? Then explain what is the test. This is a simple blood test in which we draw a sample of blood and do certain test for it. If this test is positive, for instance, is positive, it is rechecked again by another way to make sure that it is 100% positive. If it is negative, this doesn't mean that you have the disease, and we have to repeat the test again in 3 months duration. Thirdly, you have, or after this, the fifth step, to mention the pros and cons of doing the test. The pros of doing the test is to know the disease early, to start treatment early, to have better outcome. There are many new treatments now that improve the outcome of the disease or improve the outlook of the disease. Treating the disease late makes the outcome bad. You can take some safety precaution to avoid risky behavior, so you are not going to transmit these bugs to others. On the other hand, there are some cons for doing the test. In some jobs, it may affect your job. You may lose your job. You may lose your future insurance. You have to inform some person like your partner, your GP, if you are going to attend any surgery or dental procedure. You have to inform your doctor as well. Then stress on the confidentiality of the test. This test is totally confidential. You are going to deliver this the result in a closed envelope in hand, unless you nominate someone to deliver the test for you, and no one has the right to know the result of the test unless with your permission. After that, if you agree to do the test, you have to sign a consent. You don't sign a consent for blood test except in HIV and genetic tests, because the results of these tests are serious and seriously affect the patient life later on. So what do you think? If the patient accepts, it's okay. If the patient refuses, why? And try to convince him. And finally, till the result of the test appears, you have to avoid the risky behavior. You have to avoid sharing needles, tattooing, unprotected casual relation, or donating blood. Avoid the risky behavior. In needle stick injury, this is again can come as a pre-test counseling. But there are certain issues that you have to stress on. Would you tell me what happened exactly? First of all, you have to absorb the shock of the patient or the person who got this needle stick injury. I appreciate you're anxious, but I assure you that all people working in the medical field having many needle stick injury throughout their job time. But the incidence of transmission of these bugs differ and is very low. So let me ask you about the circumstances at which the injury happened. Was it before or after you drew the blood from the patient? What is the extent of piercing? Was the needle soaked with blood? What did you do after the needle stick injury? Have you squeezed your finger, for example, or just put it under running water? Have you ever checked your HIV status or hepatitis B or C before? Okay, Another issue, what I'm going to do now is to do a basic blood test for HIV and also hepatitis B and C because they can be transmitted the same way. And if it is positive, this means you have this problem from before. If it is negative, this does not mean you doesn't have the infection, but we have to repeat the test after 3 months for HIV and 6 months for hepatitis. You have to mention that you are going to write an incident report because this incident report plus the negative test result keep the patient right in compensation. So it's very important to write down an incident report for what happened. And then to assure the patient that you are going to refer him to the infection disease control clinic to start for him treatment for HIV and prophylaxis about hepatitis C if the patient check if he is vaccinated or not. This is very important, and then you assure him that you are going to follow up him and check what is going to happen. Okay. These 3 scenarios can come again as post-test counseling. Post-test counseling. You can have either patient with risky behavior or a patient with disease-defining illness or patient with needle stick injury. The situation here is different. You know that the patient is HIV positive. You start first of all to explain to the patient how much you know about your condition. Do you have any idea why this test was done? And how much you know about HIV? And at the breaking bad news, you start to tell him, I'm sorry for that, but I have some bad news for you. The results of the test that came back shows that you are HIV positive. Explain what is HIV, explain the mode of transmission of HIV, explain the treatment available for this treatment, for these bugs. There is now improvement in the treatment of HIV. There are many new medications which change the outcome of the disease. And the earlier the start, the better the result, and will improve your outcome. But it is important to be compliant with new medication because stopping the medication may deteriorate your condition in time. Also, it is important to know that some of these drugs can affect your blood test. So it is important to regularly check your blood count, liver function, kidney function. It may cause some change in the color of urine and so on. What do you feel about this? Now moving to the management plan, I'm going to refer you to either STD or infection disease control clinic. You have to avoid risky behavior, avoid sharing needles, tattooing, unprotected casual relation, and donating blood. And on the other hand, you have to inform some persons, like your wife or your husband, depends, partner, whatever, your GP. If you are going to do any surgery or dental procedure, you have to inform your doctor. If the patient refuses, ask him why. Maybe he's afraid about losing his partner. You should appreciate this, but stress on that. I appreciate your feeling, but I'm sure that you don't want to harm her or him, and you wouldn't be happy if he got these bugs. If he knows that you deceived him, he will not be supportive for you. Giving him early treatment if he got the infection may improve his outcome. So it is important to test the partner. Why don't you think about, and then we can discuss it later on another meeting. If you are not convinced that I'm going to arrange a meeting with my consultant, may be able to convince you. When discussing, stop the discussion on this limit. If you are asked by the examiner what is the next step, if he is still refusing in the next meeting, you tell him, but this in the discussion with the examiner, not with the patient, because the patient is just receiving shocking news, so you cannot give him many shocks at the same time. You should allow him some time to digest what he got and react in a proper way. Sometimes the initial reaction is not the best one. So if the examiner asks you what is the next step, if he's still refusing, you are going to tell him, I'm going to tell the patient, I'm sorry, but I'm obliged by law to breach your confidentiality, and I'm going to write down in your notes that I'm going to breach your confidentiality for the sake of your partner. You end your conversation with the patient by writing down that you are going to discuss it in another meeting, and you are going to write down in your notes, in his notes or her notes, that you informed him to tell his partner, his GP. So it is very important when you are struggling with your patient about a certain issue, and it involves a third party that is going to be injured if the patient didn't disclose his confidentiality. You start by trying to ask him in a good way. I appreciate you are caring after him. You don't want to injure him. If not, start to threaten him again in a polite way. I'm going to write down your medical records that I informed you you have to inform your partner. Here, this is a legal document. If his partner knows that he has HIV and raise a case in the court, they are going to ask for the medical record, and in such situation, they will find that you informed him to inform the partner. And this is a legal document against him. Give him time to think and rediscuss it again. This about HIV. End-of-life care is a bulky scenario. It is one of the Breaking Bad news scenarios. Again, to resuscitate or not and to ventilate or not, they are bulky scenarios. I'm going to discuss them all in one session. So I'm just going to take a few minutes to listen to your comments and questions. Any comment or question?
Hello, excuse me, ma'am.
Yes.
Hello.
Yes, doctor.
If a patient asks